Thank you. Hello, good morning. So much to SAGES for the opportunity to present and to Drs. Mellinger and Greenberg for the invitation as well. So today I'm going to be talking about how to teach surgeons in practice new tricks, really focusing on the ADOPT program that has been utilized here at SAGES. My disclosures are that I am a speaker and teacher for GORE, as well as a speaker and teacher for Intuitive Surgical. So the outline of this presentation, first I want to talk a little bit about what the model is for traditional hands-on courses, how that led to the ADOPT program, and then really this new wave of teaching that we've entered, this idea of virtual telementoring. So traditional hands-on courses are typically the most common way practicing surgeons learn new techniques. These are usually a simulated model, such as a cadaver or a pig. It's usually a half or a day-long training that occurs at a national conference or a weekend-long event. Some of the disadvantages of these traditional hands-on courses, though, is it's really just a one-time event. So it's really hard to capture how well this translates into adoption into practice. And ultimately, whoever is sponsoring the surgeons to go to these events, it's really a poor return on investment if whatever they've learned at the course is not adopted into practice. So in 2015, a new hands-on course structure came to fruition through the SAGES task force of both the continuing education and the quality outcomes and safety committees. The goal of this new structure and new paradigm was to increase the transfer of training into practice. So how are people going to utilize what they've learned at these courses and transfer it into their practice? So this gave birth to the ADOPT program. So the ADOPT program really consists of two main portions. There's structured teaching and there's longitudinal mentorship. ADOPT stands for the acquisition of data for outcomes and procedure transfer. And again, the standardized teaching approach to hands-on courses is a really key part of it. So it's not just the traditional hands-on course where you have teachers come in and they teach in their own different ways. I'll talk about this a bit, but it's really making sure that those who are training the surgeons have a very standardized teaching approach. And then even more exciting as an extension of this is that year-long longitudinal mentorship experience. So that portion is really important to make sure that surgeons are adopting everything that they've learned in the courses and that they're continuing that mentorship throughout the year. So this started in 2015, as I mentioned, with the pilot hernia program and continued subsequently until 2020, and I'll talk about that later. Obviously, we all know what happened in 2020. So there was some change to the structure as a result of that, but there were 6 years worth of programs. So the standardized teaching approach is really the heart of the ADOPT program. The idea behind the standardized teaching approach is to provide faculty with development and to structure the way that they teach. So this led to the use of what's called LAPCO Train the Trainers course. This is a course for surgical trainers, and it really teaches them a standardized technique to help with skills acquisition. So the LAPCO Train the Trainer course was developed in 2007 from the National Training Program in Laparoscopic Colorectal Surgery of England. This was a multi-center program used in England to train established colorectal surgeons in laparoscopic techniques, and the goal of it was really to improve, standardize, and benchmark training quality. So the LAPCO Train the Trainer course is a 2-day course. Day 1, coaching skills are taught with interactive discussions and simulation. The second day, the trainer participates in live cases with a trainee and is provided with their own feedback on how well they are training their trainee and how well they are teaching. So the LAPCO Train the Trainer course consists of 4 main curriculum skills: teaching structure, skills deconstruction, trainer intervention framework, and performance-enhancing feedback. The teaching structure is really learner-focused framework, and there's 3 main parts to the teaching structure: what's called the set, the dialogue, and the closure. So set, dialogue, and closure are really the heart of teaching surgeons in practice. It's a way to really standardize how to teach someone and make sure that you're falling in line with what they want to learn and what they want to get out of the course. So for set, the main focus is on preparation, assessment, aligning agendas, setting objectives, and setting ground rules. So the set is really a pre-brief. This can be started just prior to the training. It can be done a few weeks before. It's essentially a conversation between the trainer and the trainee about what they want to accomplish from the educational session. The purpose of it is really to make sure that their agendas are aligned between the educator and the learner. So the learner is getting out of it what they really want to get out of it. And the purpose of the set is to really set learning objectives and goals for the upcoming hands-on teaching session. So the set occurs prior to the teaching event. It can be immediately prior or a few weeks before. The dialogue is what is occurring throughout the training session. So the purpose of the dialogue is to find clear, consistent, concise, and common language between the trainer and the trainee, to really give performance-enhancing instruction so the learner can learn as they're going, and avoiding something that's called cognitive overload or dual task interference, where you're trying to teach multiple things at once and therefore you're distracting the learner. So the dialogue is used during the training itself. It's a standardized verbal interaction between the educator and the learner. And the standardized verbal interaction is what's known as the 6 steps. That's the mnemonic. So that includes stop, identify, explain, structured teaching, elicit check of understanding, and proceed if safe. So stop. When you're teaching someone, and this is the dialogue that you're conducting during the teaching session, the first way to start the dialogue is to say stop. So whether you want to use stop or some other word, but you really want to make sure that that's clarified when you talk to the learner in the set discussion. So you stop, then you identify and ask the learner, what is the learner trying or thinking that they want to do? Before offering your own feedback, it's important to identify what is the learner trying to get out of the situation. After that, you explain. So the instructor explains the issue, whether or not that's in alignment with what the learner was trying to do. That's where you can rectify that issue. After the instructor explains the issue, the instructor then engages in structured teaching, demonstrating next steps, what are some things they could have done differently, and all of that. Once the instructor engages in structured teaching and teaches what they want to convey to the trainee, then before proceeding, it's very important to elicit a check of understanding. So have the learner repeat back the teaching point. What did you gain from this? What do you think we need to do to progress and to move along to next steps? And then after that, once you feel as though the learner understands the purpose and how to proceed, then the learner would continue with whatever task they were doing and proceed if safe. So these 6 steps of safe mentoring are really the key to structured teaching, especially for practicing surgeons. So you have the set, you have the dialogue, and finally you finish the session with the closure. So the closure is really about the trainee self-reflecting, giving performance-enhancing feedback, what is the take-home message, and providing a summary. So just like the set, this does not have to take a very long time. It can just take a few minutes. It's essentially a post-procedure or training debriefing. The first and most important thing is that you want the learner to reflect upon what went well. So do not provide your own feedback first, just like with the 6 steps of safe mentoring. You want the learner to identify what they think the issue is before you offer that. So ask the learner, what do you think went well in this? And then what do you think could be improved? So really eliciting that from the learner is very important. And then as the instructor, you really want to guide the learner to what is the take-home message. So you don't want to give them the take-home message or tell them what it is. You want them to come up with it. So that's really making sure the learner is engaged in the process. So the purpose of the closure is to really standardize the verbal interaction between the educator and learner and make sure that at the end of the teaching session, everything has been summarized and the learner takes home what they were hoping to. So skills deconstruction is another part, very important part of the skills curriculum for the LAPCO Train the Trainer course. So as you can see here, you see this gradation of skills acquisition from unconscious incompetence to unconscious competence. So as surgeons, we are unconsciously competent for the most part. We're competent as educators, we're able to teach, but we don't really have insight into how we do that, hence the unconscious competence. So the purpose of the LabCo Train the Trainer course is to make educators and to make surgeons and trainers consciously competent. So they are able to teach, but having insight and awareness and knowing how they can do that is incredibly important. Next, you have trainer intervention framework. This is really that 6 steps that you want to focus on, the 6-point structured framework to make sure that the trainer is intervening when the trainee is not progressing. So if the trainee is not progressing, really following that 6 steps of safe mentoring and making sure that it's structured feedback. And finally, educators can only improve if they get their own feedback. So performance-enhancing feedback is also an incredibly important part of the LabCo Train the Trainer course. Trainers are provided individualized feedback on ways to improve themselves as educators. They are given learning objectives on knowledge, skills, and attitudes on how they can improve their performance. How can they become better educators? So the standardized teaching approach, as I mentioned, is really the heart of the ADOPT program. And then after that session, after that hands-on course, there's year-long longitudinal mentorship. So a mentor-mentee relationship is established during the hands-on course, and then subsequent to that, mentors and mentees will attend webinar courses, complete follow-up surveys, participate in Facebook groups, watch online videos, so various ways to make sure that they're continuing to interact throughout that year. Now, obviously, this paradigm, as I mentioned to you earlier, has had to change because of the COVID pandemic. So we weren't able to have hands-on courses during the pandemic. So this was an opportunity for surgeons to continue their professional education at home, and this led to the birth of the virtual hernia course, which was in the 2020-2021 year. So this was a virtual telementoring platform that utilized the Kind Heart abdominal wall model. So this was the publication in Surgical Endoscopy that really talked about this proof of concept using this virtual telementoring platform. And this has really led to a transformation in the way that we think about teaching surgeons in practice, what's called the REAL project, Reimagining Education and Learning. So this was the setup of the virtual telementoring program. Essentially, initially, there was a practice session to make sure that all trainees had the models and that everything in terms of technology worked. Subsequent to that, the faculty had an orientation, and then after that was that initial meeting, so orienting the trainers and the trainees, doing that set to make sure that everyone's objectives were aligned. There was a 1-day virtual education session, and then we continued with ongoing mentorship and monthly webinars for the following year. So really continuing that longitudinal mentorship virtually. So this is what the telementoring looked like. On the left, you have the instructor view. So that's the pig abdominal wall model. We focused on component separation. So there you can see a retrorectus view of the abdominal wall. So that's what the instructor was viewing on their computer screen. You can see how great the visualization is. And then on the right, you have what the trainee was doing. So the trainee had all the setup, had their computer cameras all set up, everything was sent to them. And so that just shows you how realistic the telementoring can be. So here are some of the evaluation results. I think the things to highlight are that a lot of people commented that they prefer this course. And one big theme from all these evaluations are that people actually quite preferred this method versus the traditional hands-on course. Someone mentioned usually in-person courses have multiple people sharing a cadaver or porcine model, but this opportunity provided them the chance to just have one-on-one mentoring, which was really important to the trainees. This was, my trainee was Pablo Gomez. You can see here, he has his model out on his sun deck and his daughter is watching him as I'm telementoring him from hundreds of miles away. So just the most important thing I think to take away from this is how does this evolve and what does this look like going forward? So I think we've really transformed the idea of educating surgeons in practice. And this is part of the REAL project that I had mentioned. So this 3-stage restructuring of the hands-on courses, the idea of a flipped classroom where trainees have pre-course assessments, and then they have a virtual hands-on course where they work together. Then the longitudinal mentorship, like I mentioned, and finally the community of practice. How can they adapt that moving forward. So we've really restructured mentoring quite a bit as a result. So in conclusion, educating the surgeon in practice is continuing evolving with technology and society. When educating surgeons in practice, really focus on structured teaching, this idea of set, dialogue, and closure. And the importance of longitudinal mentorship cannot be understated, really important to maximize education and adoption into practice. Thank you again for the opportunity to present.